It's truly a pleasure being here. I'd like to thank the Seattle Study Club and Orem Dental Labs for this wonderful opportunity, and it really is an honor to be part of the Seattle Study Club. I always learn so much from friends and colleagues every time I have this interaction. My charge for today was to discuss the diagnostic and treatment planning considerations as far as the All-on-4 treatment protocol is concerned. Implant dentistry has changed a lot over the last 5-10 years, but one of the things that hasn't changed is that it's still a prosthetically driven discipline. I'm sorry to say, surgeons, but patients really don't care about the titanium implants in the bone. They're really coming to us for functional, good-looking teeth. And for functional, good-looking teeth, we really do need good teamwork. We need good communication with our surgeons so that we can provide the surgeons with sufficient information so that we can fabricate an ideal biomechanically sound restoration. So we begin with the end in mind. With any aspect of restorative dentistry, we always have to visualize what the end result is going to look like. Whether we're doing veneers, whether we're doing crowns, or even a complete denture, if we do not have a clear visualization as to what we're going to achieve, it's very dangerous to embark upon treatment. So when we begin with the end in mind, there are a couple of questions in mind. What is it that the patient exactly wants? And how do we get there? So let's start with, what does the patient want? When patients come to see us for implant-supported restorations, they are usually looking for a fixed restoration. I haven't really come across many people that come to see us and say, you know what, I want a denture and implants. They're looking for something which stays in their mouth, some fixed permanent teeth. As clinicians, we have to be detectives and decipher if that is actually possible. And when we're trying to figure it out whether the patient is a suitable candidate for a fixed versus a removable restoration, there are a myriad of details clinically that we need to look at on a day-to-day basis. Now, what does the patient want? When we ask the patient, what do you want? Now, we have to think about patient preferences. We have to think about which type of prosthesis has a higher complication rate, and is cost an influencing factor? So let's look at some of the literature. What does the patient really want? And that really depends. If you look at studies out of the United States, most patients who present for implant-supported restorations are looking for fixed restorations. However, in Europe, they're equally satisfied with fixed and removable. When these patients were asked what is the most critical factor, they talked about stability and chewing efficiency of the final restorations. Those patients that had overdentures complained about chewing stability. They complained about the aesthetics. Those patients that had fixed restorations complained about the cost, and they complained about the cleaning. Now, what type of prosthesis has a higher complication rate? Once again, when you look at the literature, removable implant-supported restorations have a much higher complication rate. And although they're easier to manage, these complications actually get worse over a period of time. When we look at the fixed implant-supported restorations, most of the complications occur on posterior teeth, but these do not get worse with time, which means that we have less time spent on fixed restorations. What does that mean for you as a restorative dentist? It means decreased chair time dealing with complications. Now, is cost an influencing factor in regards to what the patient will accept, whether it be fixed versus removable? And most people feel that if we offer the patient a maxillary overdenture, they're more likely to accept treatment. But when you're thinking about cost, you've got to think about it in two respects. One, what is the cost to the patient? And two, what is the cost to the dentist? We just went over that complication rates for maxillary overdentures are much, much higher. If you look at lab fees for a maxillary implant-supported denture as opposed to a maxillary fixed implant-supported restoration, lab fees are very similar. So the costs from a dentist perspective are much higher when we decide to do removable maxillary implant-supported overdentures. Okay, so the next question becomes, how do we get there? We talked about beginning with the end in mind. We talked about diagnosis and treatment planning factors that we have to think about on a day-to-day basis. So there are a number of things that we think about, and all of these factors have to be given consideration when we're planning. There are 7 diagnostic factors, and we're going to go through the first 3 in the first part of this presentation. The beginning point of any rehabilitation is positioning the maxillary incisal edge. Once again, whether you're doing veneers, whether you're doing a complete denture, correctly positioning the maxillary incisal edge in the patient's face is key to the starting of that restoration. And most of these guidelines have been given to us from complete denture textbooks, aesthetics, phonetics, the F position, the V position. Most textbooks don't talk about the mandibular incisal edge position. And that becomes really important because a lot of these patients that have missing maxillary teeth, the lower incisal edge has over-erupted. And that mandibular incisal edge position really will impact the functional aspects of the rehabilitation. We need to think about the anterior guidance and how that patient will function over a period of time. So when you start looking at two patients side by side, once again we have to decide, is this particular patient's incisal edge in the correct position? And the patient on your right side, the incisal edge is further forward and it has over-erupted. So if we are planning an implant-supported restoration, we're going to think about raising that incisal edge, maybe positioning it further lingually. And when we do that, it will have an impact on the implant placement. If you look at the ideal tooth position in relation to the bone, prior to placing the implant, the surgeon will actually have to go in there, do some bone recontouring so that we have sufficient running room from the implant to the emergence profile of that restoration. So when you look at this type of restoration, is this particular patient with very minimal resorption a candidate for an all-on-4 type of restoration? And most people have this misconception that this patient isn't because you have to do this tremendous amount of bone reduction all the time. That actually is a misconception. Patients with minimal resorption can be treated with the All-on-4 treatment protocol, and all we're doing is that we're not replacing the pink, we're just replacing the tooth portion. This is your more classic type of All-on-4 type of restoration where the patient has lost a significant amount of tissue and we're replacing pink as well as we're replacing white. The next factor that we need to think about is restorative space. How much space do we need for the particular type of restoration that we're going to fabricate? And this is one of the most common errors we see on a day-to-day basis, where the restorative dentist is really running out of room and the laboratory technician is really trying to do some gymnastics to try and create something which is going to work once the implants are integrated. When we look at ceramic-based restorations, we're looking at about 10 millimeters minimum of space for a screw-retained restoration. When you were looking at implant-supported hybrids or an all-on-4 type of restoration, we're looking at least 16 millimeters of space. Now, where does that 16 millimeters go? It goes to all the components, the tooth, the acrylic. What happens if we compromise that space? If we compromise that space, we get a biomechanical failure. And this is a bad day for everyone, especially when it happens early after the restorations have been delivered. The next factor we look at is the lip support. Lip support is a key factor in deciding whether you're going to do a fixed versus a removable restoration. And this is something that we have to decide very early on in the patient's treatment so that we can communicate the reality of what we're trying to achieve for our patient. So when a patient comes in, we take a lateral shot with the denture in and with the denture out. And in this particular example, you can see that the patient's lip is very well supported. So this patient is a candidate for a fixed implant-supported restoration. When you compare that patient to this one, you can see the concave facial profile. The patient has an excessive lack of lip support. So this patient could be a candidate for a removable implant-supported restoration. So how do we decide that? Say a patient comes to see you with an existing denture. You have to evaluate the denture, and if the denture is inadequate, we remove the denture and we fabricate another denture. Now, when we're fabricating this next denture, we have to communicate to the lab that we want to do a try-in without a flange. So without a flangeless try-in, we can get a realistic evaluation if this patient needs lip support or not. We try the flangeless denture in place, and if it looks correct in the patient's face and if it provides adequate amount of lip support, it really will be, this patient will be a candidate for a fixed implant-supported restoration. So the questions I would then ask you over the next 20 minutes so that we can discuss how we're going to do things is, what is the impact of excessive gingival display? How much bone reduction do we need? What is the occlusion that we're going to be placing on the immediate load provisional restoration? And if you're going to do bone reduction, how are you going to communicate that bone reduction to your surgeon? So I'm going to give you about 20 minutes just so that you can discuss these factors, and we'll come back and we'll try and answer some of these queries for you. Thank you. Okay, so we had talked originally about 7 diagnostic factors, and we had covered 3. So now we're going to go ahead and start to cover the remaining 4 parameters that we need to look at. The next thing we look at is smile line and lip length. And whenever you're doing any type of restoration, this really comes into quite a lot of consideration. The literature has shown low, medium, and high smile line. The patient on your left-hand side, whether you're doing a single tooth or a full mouth rehabilitation, is probably the most challenging type of patient to treat. Now, what impact does lip length have on your restoration? This is a patient with a short lip. In a patient with a short lip and a high smile line, the transition zone between the tissues and the restoration will be visible, and obviously this will be aesthetically unappealing. So this is something that we really want to try and avoid. If you're looking for that first case, you want to try and look for a patient which has a long lip so that the lip really drapes over the restoration. When the patient smiles, you do not see that transition zone. What impact does excessive gingival display have on our overall treatment planning? Once again, we have to come to a diagnosis. We have to ask ourselves, what is causing the excessive gingival display? Once we figure that out, we have an appropriate treatment modality to address it. There are many causes of excessive gingival display. What is the relevance of excessive gingival display? If the patient has a lot of display, it will depend on the type of prosthetics we're going to use. If we decide that we're going to keep that gingival display, we may decide to use ovate pontics and sculpt the gingiva. We may decide that we may need to do additional bone reduction for these types of patients. And there may be some other treatment modalities required before embarking upon an implant-supported fixed restoration. So if an edentulous patient comes to see you, what do we look for specifically? We ask the patient to take their denture out, and we ask them to smile really big. And at that point, the patient's probably going to ask you, why do you want me to smile without my denture? The reason we want them to smile is we're looking for ridge display. In this particular example, you can see that when the patient smiles, there is no ridge display. And if you compare this patient to this one, this is a red flag. If you are treatment planning an implant-supported fixed restoration, which is going to include pink ceramics, and the patient has this higher smile line, that transition zone is going to be very visible. And aesthetically, it will not turn out to be a favorable situation. So in this type of patient, we do have to reposition that transition zone a little bit further up, and we have to utilize bone reduction to be able to do that. We've been talking a lot about space. We don't just need the space for aesthetics, we don't just need the space for biomechanics, we also need the space to contour the restoration appropriately so that the patient can clean it. Now, when we talk about contours, it's a prosthodontic requirement, but really it's a surgical responsibility. The surgeons actually have to provide us with that space. Our responsibility is to communicate that bone reduction to them. So when you start looking at this type of patient, and this patient has an obvious lack of lip support, and this patient comes to see you and says, I really want a fixed restoration. You have to ask yourself, is it possible in this type of patient? And the things you need to think about is, what are the complications that are likely to occur? So in this particular patient, the patient has suffered a lot of resorption, so the implant, if there is bone available, the implant will be more palatally placed, and for aesthetics, the incisal edge will be a little bit further forward. And the problem that we have is now we have this shelf between the implant and the incisal edge, and that shelf is very tough to clean. It's very hard for oral hygiene purposes, and the patient's lip actually caves into that area, and you get this little crease underneath the nose, and these are all aesthetically unattractive. So what are the options for these types of patients? Once again, we want to try and avoid this shelf. What we're trying to fabricate is a restoration with a nice straight emergence profile. We do not want to have this ledge visible. So one of the ways in which we can do that, if there is sufficient bone available underneath the floor of the nose, we do alveolectomy, raise the implant platform a little bit higher so that we can start the contours of the restoration much higher up. In that way, we can get rid of that shelf which initially was there. Now, all morning we've been talking about, over the last 20 minutes, we've been talking about all of these factors which influence our diagnosis and treatment planning. And most of the factors that we've talked about really result in the need for bone reduction. Now, we've got to be very careful about that, because this particular treatment protocol or treatment concept, once again, there's a misconception that you have to do this bone reduction every single time. There has to be a specific indication for bone reduction, hiding the transition zone, making sure that there's sufficient bone volume for implant placement. In those periodontally involved patients, they have a very thin ridge and reduce the bone to get enough volume of bone to place the implant in. We need to create enough space for biomechanics of the restoration, enough space so that we can contour the restoration appropriately, so that it has a nice convex undersurface, and definitely to improve the emergence profile. So bone reduction shouldn't be done haphazardly. It has to have a specific indication. The next thing we look at is appropriate tissue contact. Like with any aspect of restorative dentistry, our provisionals determine what our definitive restorations are going to look like. Our provisional restorations serve a purpose. So when we're immediate loading those implants, we shouldn't just think of it as a temporary restoration. It's a provisional which is going to provide us with a lot of information. That provisional restoration is designed to reduce food entrapment, it's designed to sculpt the soft tissue, it's designed to have cleansable contours, designed to assess the patient's speech, and even designed to assess the occlusion, the vertical and horizontal overlap of the anterior teeth. In an ideal world, we want a convex undersurface. We're going to be shaping that tissue so that the tissue has a concave surface, so that the restoration can go in there nicely and the patient has a very good chance to be able to clean that restoration very, very well. Now, the last thing we start thinking about is what type of occlusion do we put on the immediate load provisional restoration? And this part is, I would say, somewhat controversial. If you look at occlusion as a topic as far as implant-supported restorations are concerned, there really isn't any solid science behind occlusal philosophies as with implant restorations. With the immediate load provisional restoration, the rationale is the further back we go, the higher the force is. The further back we go, the weaker the quality of bone. So the occlusal scheme for the immediate load provisional restoration is essentially we're trying to protect the implants that are underneath the most load. Okay, so with that said, we definitely want good AP distribution of the implants. We definitely want no premature contacts. We definitely want canine guidance. As far as occlusal scheme is concerned, most of the contact is placed on canine to canine. And that is designed on purpose so that the patient can't function too much at the back. And the patient really won't have that force, won't be able to generate that amount of force to be able to break these types of restorations. So I hope in the last 20 minutes you have an idea of the diagnostic factors which become critical and a systematic approach as to how we can predictably fabricate these types of restorations. I want to thank you for your time and attention.